Hi, everybody, and welcome back to our next episode of ReWalk's Topics in NeuroRehabilitation webcast. I'm Jill Butler, and today we'll be talking with an expert in exoskeleton research, Pierre Asselin. Pierre is a biomedical engineer with interests in applying technology towards multiple different medical interventions. For most of his career, he has applied technology towards improving the quality of life and health for persons with spinal cord injury. And currently, he leads a Veterans Affairs project that applies the ReWalk Robotics personal exoskeleton to enable persons with paralysis due to spinal cord injury to walk again. He is involved in all aspects of this research study, ranging from devising technical improvements to teaching and training participants how to actually utilize the device, to acquiring the data for outcome measurements, to publishing manuscripts and preparing grant submissions. His input to this exoskeleton project has been critical towards advancing the field in general, and specifically with earning FDA approval for the ReWalk exoskeleton. Pierre's talk today will dive into some of the exciting data he's been involved in publishing that demonstrates the amazing positive effects exoskeleton use has on the bodies of those with paralysis. Hi, Pierre. It's great to talk with you today.
Hi, thank you, Jill. It's nice to meet you.
Pierre, I'm really excited to have you on to talk about your work with exoskeletons for personal use, because this is a topic that always generates a lot of excitement and curiosity. As clinicians, we can all intuitively understand, I think, that we want our patients achieving their highest level of mobility, but many questions tend to arise as to the potential for sufficiently meaningful outcomes to justify an individual really pursuing personal ownership. I think the results of the studies that you'll be discussing today will help to answer many of these questions, but to our viewers, let us know in the comments if you have any questions that don't get answered during the episode today. Also, don't forget to like and subscribe to this video if you want to see more talks like this one. And with that, Pierre, I'll let you take things from here.
All right, great. Thank you for that wonderful introduction. Let me get started with the screen sharing here. The work I'm going to present is entitled Observed Effects of Walking with Powered Exoskeletons on Soft Tissue Composition. And the data I'm going to present is going to be focused on the pilot study that we started. And the pilot study is a prospective single group observational study. The aims of the study were, there was a various number of them, but the ones that I'm going to discuss today was the development of our training protocol. We measured pressures underneath the feet. We observed some energy expenditure while walking in the device and observed changes in body composition. So the inclusion-exclusion criteria was very similar to what is the clinical inclusion-exclusion criteria. The only added difference is we do a lot of bone mineral density work, and we thought since spinal cord injured persons have a prevalency of fractures, we should exclude some people based on that. So we had a combined bone mineral criteria at the hip of a negative 3.5 T-score for a cutoff, and the knee was less than 0.6 grams per centimeter squared. And that was a custom scan for the knee. The hip is just a normal standard hip scan. So our training, during the time that we had the device, the training protocol was not as structured. So we incrementally devised a training protocol. So we started off with a lot of standing balance. A lot of our participants had a lot of trouble with that at first. So we would do 2 standing, 2 crutches, balance with 2 crutches, balance with 1 crutch. Then we would walk indoors. And then as they progressed in their skill, we would walk outside, walk on grass. We also included some activities of daily living, such as doing some countertop activities. We had a mixture of different skill levels. We wanted to test their ability to load and how much load did they have on their legs as they walked. So in order to do this, we had a spinal cord injured group and an able-bodied group. The spinal cord injured group were at 2 different skill levels, those that needed no assistance to use the device. So the trainer was completely hands-off. And then you had another group where they needed some level of assistance. In order to measure the pressures underneath the foot, we used the F-scan system. That's a sensor array that's just stuck onto the insole of the shoe. So the person's foot is directly onto the sensor. So it measures only the person and will not measure the weight of the exoskeleton. In this diagram here, you have the three groups. So the black bars and lines on the graph are the able-bodied group. The blue are our spinal cord injured group that needed no assistance, and the red are those that needed some minimal assistance. So the chart over here is all three groups, where you can see the spinal cord injured group has this typical M-shape loading profile. Those that needed no assistance had a dampened heel strike profile, and you can see these are the three phases here, just kind of averaged. So you can see the blue was a dampened version of the able-bodied group, and then it continued to rise until toe off, and that we presume is because of how they're loading with their crutches. And then those that needed some level of assistance were offloaded about 50%. So we assume a lot of them were either offloading onto their crutches, or the trainer had some level of effort that is unaccounted for. So then after that, we had a few more participants. We wanted to take a look at the metabolic activity. We just did a one-time snapshot of that. We used Oxycontin Mobile by CareFusion. We asked them to do 6 minutes of sitting, 6 minutes of standing, 6 minutes of walking in the device. We essentially just did a 6-minute walk test while they were walking. Still the same participants, just a few more. And then during the sit, they were at 3.5 milliliters per kilogram. So that is a typical resting metabolic activity, slightly elevated when they were standing. And then when they were walking was at 11.2 milliliters per kilogram per minute. So that's a moderate activity. We did not do a maximal test. Those tests are a little bit difficult, and we were just in observation. So we used a predicted maximal test, used based on an equation. So there's two different equations that we used: max test based on a leg exercise, and then a max test based on an arm exercise. So then we calculated a VO2 reserve of approximately 24% and 35% based on an arm exercise. And then we looked at their heart rate at the same time. Their resting heart rate at sitting was 70 beats per minute. Standing was slightly elevated at 81. And then as they walked, it was much more elevated at 118 beats per minute. So that was a significant increase. If you look at what that would be based on a heart rate reserve, and that would be about half of their heart rate reserve. So how does this compare to some of the other reports out there? So Nick Evans from Shepherd did a very similar trial using the Indigo device. He included five participants. He had 2 walking trials of 6 minutes. One was a self-selected walking at comfortable speed. The second was, the instruction was walk safely, but as quick as possible. And what he reported was the self-selected comfortable pace was at 9.5 milliliters per kilogram, and then the faster walking was at 11.5, which is very similar to what we reported here at 11.2. His report of the VO2 reserve was at 51 to 63%, whereas our heart rate reserve was in a similar level at 48%. And so what does this mean? The American College of Sports Medicine recommends a minimum training intensity threshold for improvement in VO2 and lactate threshold to be approximately 40 to 50% of VO2 reserve or heart rate reserve. So we're right in that target for improvement in that metabolic capacity. And so, that metabolic capacity means that you're going to be doing some exercise. So we wanted to also take a look at what body composition would be affected. So here, we use DEXA. This is this diagram here is just the standard image that you see on the scanner. And we performed it just like you would a normal, typical clinical scan, supine. We alter it a little bit by wrapping each patient up with a sheet just to prevent any type of movement, not much of a change. And also, we only included those participants that were able to complete at least 40 training sessions. So here are our results, where the total body here, all the way on the left here, was not significantly different, but trending. When you compartmentalize it in fat and total and lean, the fat mass for the total body was significantly different, and it's concentrated in the trunk, as you can see here. The legs and the arms were trending towards a significant difference, but we did not get statistical significance. And these bars here are the lean mass, where we didn't see any notable effect on lean mass. Again, how does this compare to what other people have done? So there's Corella and others published on the Exo device. They did a 6-week progressive training where they trained people for 3 times per week for 60 minutes. They also used DEXA for body composition, so it's a nice comparison. This is a broad view of their results, which, if we want to try to focus it a little bit, their lean mass was elevated and their fat mass was decreased. So we didn't see the increase in lean mass. So there could potentially be some differences in the intensity, how they trained. It's difficult to kind of speculate, but that was that was the only difference between our studies. So why is that so important? A systematic review has shown no intervention in spinal cord injury to be able to reduce fat mass. And even more specifically, there was a case series where they had 13 participants enrolled in a 16-week exercise program, 3 days a week for 2 hours, and they showed no significant changes in percent body fat or lean mass. So, it's huge to be able to show some level of effect on body composition. Even when you take a look at FES, functional electrical stimulation, those reports can show some dramatic improvement in muscle hypertrophy. However, they also show no negligible changes in fat mass. So in review, independent walkers are able to walk faster with their full body weight loaded on their legs. Metabolic activity is at a moderate level, and it doesn't seem to be exoskeleton specific, which is good. Regular walking with the powered exoskeleton has the potential to reduce body fat regardless of device. And there's no other intervention that's been able to show that at this point.
That's awesome. Thanks so much, Pierre, for a great talk and some really exciting insights into that research. I love how the data from these studies can help guide the implementation of this technology into, right into rehab treatment plans. It's something that we're already doing with people, is trying to help them, get their most appropriate level of exercise intensity and reach these real life gains. And so that's really exciting to see that, and especially across different exoskeletons as well, that we're able to see these really important results. We have a few follow-up questions for you. The results of the metabolic activity study show an ability to get into the moderate intensity range when walking in a powered exoskeleton. From what I've seen in working with patients, especially newer patients in the device, we can get them up and walking, but sometimes I feel like it might be difficult to get them into this level where they're achieving this higher level of intensity. Do you have any training tips that you could give to help therapists get their patient in that range?
Yeah, I mean, in my experience, the more you have the person work and do the transition, even if they're not walking tremendously fast, as long as they're constantly trying to shift their weight, crutch appropriately, and the trainer provides just enough assistance, whatever the minimum amount of assistance necessary in order to get them to be safe in using the device when they're learning is the appropriate amount. Once I find that once the trainers start to provide a lot more assistance, these guys find it to be really easy, and so in order to challenge them, you always want to push them in that way.
Yeah, that's a good point, especially about not necessarily needing the speed to be that fast to achieve the results, but more so just backing off on level of assistance. I have a feeling that it might be a similar answer for the second question I have, but so same thing for the limb loading results. I find those to be really interesting as well, the way that you saw that if the more assistance someone got, the less they were actually loading their own limbs. I'm not sure as therapists we're realizing that our manual physical assistance was necessarily having that big of an impact on how much loading our patients' legs were getting. So can you speak a little more to that, or any specific tips or things that you use with your patients and therapists to help them get off their crutches?
Sure. So we haven't looked into specifically having a therapist providing more assistance and then offloading them in order to take a look at the reaction. I think it's mostly those people that need some level of assistance are a little bit more insecure, right? So they don't feel their legs underneath them. So loading onto their crutches provides them that level of security. And in addition, they're just not that skilled yet. So it's just a level of skill, not necessarily attributed to the amount of assistance that their trainers are providing. And I think that just comes with time, and everybody learns it at a different pace. So some people adapt really quickly. Some people have a little bit of residual function that helps them, with some proprioception, things like that. So everybody's a little bit different, but it's just practice, right? Just like to getting to Carnegie Hall.
Absolutely. I'm glad to, have you say that as well, because, I've said it a lot in the past, and I think patients, like with anything else, are really excited to just get to that end point where they're proficient and they're walking again. But to hear from someone with so much experience, seeing like so many different patients in the device achieving that level of independence, just knowing that it does take time, like anything else good, right? So one more question. So you presented a lot of great data here today on the biomechanical, physiological benefits of regular exoskeleton use. And the VA has been such a great partner with ReWalk in terms of advocating for their patients to promote personal exoskeletons for home and community use. Can you comment on any recommendations you have regarding how clinicians can help veterans to become successful users in the home or community setting?
Yeah, I mean, certainly identifying the appropriate candidates is important. Everybody has a different intention for what they would like to try to use the device for. So it's important to ask them, what their purpose is. If it's, there could potentially be something that they may want to try to do that isn't safe, and the therapist needs to say, look, that's not safe. And then there's other things that they may want to do, and that's perfectly appropriate. They want to walk down Times Square, let's say. Being in the Bronx, we are able to do some field trips of that nature. But for the most part, we mimic whatever we can in our medical center. Certainly try doing a kitchen setting, because we see a lot of people want to do those type of activities there. Ramps are very, very important, because you run across that everywhere. Some people just want to utilize it in a mall, which is fine. So, we just practice more on indoors. If they're really only going to utilize it outdoors and they've got a gravel driveway that's hard packed, not loose, we try to mimic some of these type of environments.
Right. Great ideas. All good tips. Thank you so much, Pierre, for a great talk. And thank you very much for your time here today.
Yeah, no, thank you for having me. This is a great series.
To our viewers, we hope that you also have been finding these talks interesting and helpful. Don't forget to reach out in the comment section with any questions or thoughts you have about this talk, about the benefits of exoskeleton use in the spinal cord injured population. And also reach out privately through our website's contact page if you have any patients in mind that you'd like to try in this technology. Please also make sure to like and subscribe to this video using the buttons below. And we hope you tune in again with us next week. Have a great week, everybody.